All right, so that takes us through staff and appointee reports for the agenda planner for the next, 4 meetings that we've got. And it takes us to item 7, presentations for general information. And we are fortunate to have the 2020 annual coroner's report. And Leon, I got this as quick as we can so we can take value of your time. So we're lucky to have Dr. Leon Dr. Leon Kelly here, the El Paso County Coroner, and he is accompanied by Dr. Robin Johnson. So Robin, you might want to come up now at this time too. And again, Leon, I want to thank you for your patience and flexibility as we change the date of this. But now we even get more current information, and I'll turn it over to you.
All right, thank you very much. Thanks for allowing us to be here today. So I am the El Paso County Coroner and Chief Medical Examiner, and I'm here today to present my annual report, which is something that I put out every single year. In the last essentially 100 years, public health has, across not only here, but across the world, has doubled human life expectancy. And the way that we've done that, certainly not me, generations before us, is better access to cleaner water and better food, vaccinations, and the dawn of modern medicine, which includes antibiotics and better obstetrics and all the kind of scientific pharmacologic advances that we've made. And just as important as those scientific discoveries is the policymakers that have been able to deliver on those scientific advances, which is what puts me here today. Our job, my job as the coroner, is to essentially figure out where we've come up short, right? Where the worst case scenarios have happened, where we have failed, what we need to do better. And then I come and I present that to great folks like you and to my colleagues behind me at Public Health. And we get to the work of fixing it. And we are the beneficiaries of generations of collaboration, innovation, and hard work. And so times like this is now our responsibility to do those same things for future generations. And so my report is where that conversation begins. And so we will start with that. Can I drive here or somebody else? There we go. Okay, so.
Are you going to do it now?
Sounds good. So that's fine. Look over here. Okay. So first, the office of the coroner. What does the coroner do? The coroner, by state statute, is responsible for investigating all deaths that are sudden, unexpected, or non-natural, and that's spelled out specifically in our Constitution. In addition to figuring out how and why people die, my job is to pronounce death, determine cause and manner, which is really the big thing, and then identify human remains, notify next of kin, which you can imagine is one of the more difficult things that we do. Investigate any deaths that occur in the presence of law enforcement or any state or municipal facility. And then really anything that constitutes a public health risk. The drafters of our Constitution were very smart, and they said, hey, we need somebody whose job it is to figure out what went wrong so we can do better. And that's my responsibility. I also spend a lot of time in court testifying as an expert witness, as well as my colleagues. So when we had to adjust last time, timing, that's pretty much every day of my life. If you've ever sat in front of a courtroom waiting to testify, I will have wasted probably thousands of hours of my life staring at walls, waiting for prosecutors. That's right. So, and then one of the few things, there's not a lot of really good things I get to do, but one of the good things I do get to do is grant tissue and organs for harvest in cases where we can use something very, very tragic and make something really, really great out of it and save people's lives. So next slide. So my office investigated just over 6,000 deaths last year. And this is everything from, I was on a hike and I found a bone that ends up belonging to a deer, but we still have to go out and deal with it, all the way up to, mass shootings and national media gaining events. Of those, a little over 6,000 cases, about 1,300 of those required an autopsy or some sort of examination in our office. And we had a huge jump in 2020 over 2019, a 25% increase in total number of cases investigated. Some of that's going to be due to COVID, but not all of it. And then we had almost a 10% increase in the number of autopsies. You expect as your population grows that your case numbers are going to go up, but they should go up at a very relatively predictable rate. And last year was a fairly dramatic increase. And here is the state of Colorado, and our office is the largest coroner medical examiner's office in the state of Colorado. One of those reasons is because El Paso County is usually tied or very close to population with Denver County. But more importantly, our office acts as a regional medical examiner for much of southern and eastern Colorado. So all the counties that you see highlighted there are counties that we perform the autopsies for. And in Colorado, other than Denver, really, the coroner is still an elected position. About half the country has moved on and evolved to what we call the medical examiner system, where my job, the chief medical examiner, is an appointed position. About half the rest of the country, it's still an elected position, and which is fine. It's always good when you get to pick your leaders and people who represent your government. The challenge that we have here in Colorado, however, is that the requirements to run for coroner have not advanced since 1876. So to be coroner in El Paso County currently, you need to be 18, a registered voter, and a non-felon, despite the fact that in the last 100 plus years, close to now 150 years, the job requires much higher qualifications than that. So most of these counties have what we call lay coroners, which are non-physician, non-forensic pathologist coroners. Many of them own funeral homes and things like that. And so they can't do autopsies. They're not doctors. And so they bring those cases to my office, and me and my colleagues, my staff, perform those autopsies and then directly tell them, here's what you're going to put on the death certificate. So it's kind of evolved naturally over time to be a regional medical examiner, despite no laws or statutes in place that would necessitate it. Our biggest contributors are, Teller County, which is good because we share a judicial district, and then Fremont County. Makes sense. Most populous counties that surround us. Next slide. And here is really the core why I'm here. This is what I spent 13 years after high school to become a forensic pathologist, so I could fill out this piece of paper. And this is a death certificate, and a death certificate is a legal document. Everybody who's born gets a birth certificate. Everybody who dies gets a death certificate, and it's important. It's the foundational piece of data that we use at public health and others to drive advances, right? And we have to start by knowing what's wrong before we can get to fixing the problem. And on the death certificate are three key things that I deal with. The cause of death. Why is the person died? They were alive, now they're dead. What happened, right? We're going to talk about a lot of those today. Gunshot wounds. We're going to talk about stab wounds, multiple blunt force injuries, heart attacks, things like that. What's the issue? What's the event that occurred that derailed their life and resulted in death? Manner of death is the category in which that death falls. And there are 5 of them. It's 5 little check boxes. And every death that's ever happened in the history of the world has to fall into one of those 5 categories. And we'll get to those in a little bit. And then what we call part 2, which is the contributors. So not the things that directly killed you, but the things that certainly didn't help. Let's say you had a heart attack. You'd say what we call atherosclerotic cardiovascular disease. Fancy way to say the person had a heart attack. And then in part 2, you'd put things like diabetes or smoking or some of these other things that can contribute to the person either getting that disease that killed them, or we know that if you have some of these coexisting diseases, much like we saw with COVID, when you have some of these other things, COPD, you've got obesity, you've got diabetes, we know that for all injuries and all diseases, people who have some of these other difficult disease states do more poorly. And so it's important to keep track of those as well. And here's the breakdown of those manners. And like I said, there's 5. Unfortunately, on this slide, there are 6. And I'll explain that in a second. But there are natural, accident, suicide, homicide, and undetermined. There's a few unclassified, and unclassified are deaths that are in utero. And so if the child is stillborn, they don't get a birth certificate because they were never alive outside of the womb. And so they can't get a death certificate because you can't die if you've never technically legally been alive. And so they go into that other category. And here's the breakdown in our office. Accidents usually top out, and we'll talk about why in a second. Naturals are always up there too. You don't see that on the news, 6 people died by heart attacks last night. But that's ultimately the goal of life, right? To live a long, healthy, prosperous life, get to an advanced age, and then die of natural diseases. I don't see a lot of those people in my work. And suicides, which we'll talk quite a bit about today, and then homicides, which garners the vast majority of the attention of the local media, for obvious reasons. Next slide. And here's our accidents. Our 2 big ones are always going to be drugs, number 1, and then motor vehicle crashes are going to be number 2. And the story really of 2020, after you get past the gorilla in the room of COVID, is really going to be drugs. And we'll spend quite a bit of time talking about it. Motor vehicle accidents kind of comes up there, number 2, and then everything else falls to a distant third and beyond. Next slide. And this one's tough to see, but our drug deaths jumped from 130 deaths in El Paso County to 186 total from 2019 to 2020. So a massive increase in our drug-related deaths. And these are all accidental. These are not suicidal drug overdoses. And we're really up across the board. Fentanyl is what's garnered the most attention locally and nationally. It's a powerful opioid medication, and we've been expecting it to move this direction for a very long time, and certainly it's here. But that's not the only thing. We saw increases in methamphetamine and heroin and our cocaine. The areas where we are succeeding is and what we saw 5-6 years ago, which were predominantly prescription drug overdoses. We've done an incredible job in many at the benefit of the person to my right here in her efforts of bringing those down. But unfortunately, as it has since the creation of drugs, it evolves. Where you put pressure, you decrease, and unfortunately, it's like a game of whack-a-mole, and it pops up someplace else. It's an arms race, and the better that we get at getting those drugs off the street or educating folks to not use them and getting people clean, then another drug comes and gets imported, and we start all over again.
Dr. Kelly, do you mind taking any questions during your presentation?
Absolutely, anytime.
Okay, thanks. Some of the people watching may wonder, and I think I know what methamphetamine and cocaine and heroin. Can you talk a little bit about what fentanyl is and about that substance and why it seems to have gone to the head of the class here?
Absolutely, and that's actually the topic of the next slide. So we'll get to that in a second. Great question. I think before we move on to the next one, though, I think what's important is this is a very busy slide. And the reason it's busy is because this is every death, the drugs also listed in combination. And so you can see, and it's not just you just use heroin, you just use fentanyl. You often use heroin, fentanyl, and methamphetamine all together. And so a large portion of our drugs, 40% of those are because it's a combination of drugs. Either they're using 2 drugs at the same time, or your drug supply has been contaminated either intentionally or unintentionally with multiple compounds. And you can imagine why every one of these drugs is dangerous, but in combination, the likelihood of negative outcomes, including death, increases dramatically. And that's the problem that we've seen increasing over the last several years, is the use of these drugs in combination. So the next slide, I believe, yes, deals specifically with fentanyl. And here's the U.S. and everything in blue, which is the entire eastern half of the country. Is the number one drug. This is from 2017, but it's true year after year. The number one drug present on a death certificate. Now there might be other drugs too, but the number one drug present in every one of those blue states is fentanyl. The number one drug present on a death certificate in every one of those reddish pink states is methamphetamine. And that's still true this year. Methamphetamine is still the highest drug that we see on those. But about 4 or 5 years ago, we began to be warned by the CDC and the Drug Enforcement Agency that fentanyl, which is under the umbrella of opioids, which is our painkillers, similar to heroin, OxyContin, morphine, all of those, it's synthetically derived and has a much higher potency. So we typically use morphine as kind of the standard, and fentanyl is about 100 times more powerful than morphine, and it's about 50 to 80 times more powerful than heroin. And when I say powerful, that means more toxic, more likely to kill you. And then you can see kind of the relative lethal doses there in those two little vials. But we were warned several years ago that fentanyl was making its way westward, and we've seen on the East Coast, kind of the Rust Belt areas, that when the amount of fentanyl increases in your community, your deaths are going to skyrocket because the very dangerous nature of the drug itself. And so we've seen it. I think 4 or 5 years ago, we were at 4 fentanyl deaths. And then we jumped up, I think, to 9. And then we jumped up to 21. And now this year, I think we're up to 47, I think, in 2020. And so that exponentially increasing fentanyl presence in our community is what's going to drive, moving forward, many of those deaths. Not just fentanyl alone, but oftentimes fentanyl in combination with other drugs. So next slide. Here's just a little bit of data. So 8% of the prescription, or 8% of our drug deaths, the medication that was used was prescribed by the physician. This was a much higher percentage 5 or 6 years ago, when the big problem after methamphetamine, when we talk about our opioids class, was prescribed opioids. We've done a great job of getting that number down. 67% of our accidental drug deaths were male, and you'll see that's a common thread throughout many of our challenges, particularly in the behavioral health arena, is that males dominate most of these categories. The average age of death is 41. We've seen, there's maybe a month ago, it came out the second half of 2020, and Americans' life expectancy dramatically fell for the first time since World War II, over a percentage point across the board. Some racial and ethnic groups were closer to 3% decrease, a 3-year decrease in life expectancy. A lot of that's going to be COVID. Not all of it's going to be COVID, because we've seen skyrocketing drug death rates across the country. And the average age is a young person, right? The younger you die, the more impact you have on that life expectancy average. About 2/3 are going to have a history of prior substance abuse or addiction. So these are people who have been treated, they've been in programs, they're known to have these struggles. That shouldn't be super surprising. Substance abuse and addiction is a very, very difficult disease to manage. But it does tell you that about 1/3 of the time, these are people that are relatively new to their substance abuse, right? But when you have things like fentanyl in your drug supply, all it takes is once. So we have a couple different groups that we have to figure out how to impact. About 20%, 1 in 5, have a history of known mental illness. This is no doubtly a gross undercount, because we know how many people have untreated, undiagnosed mental health issues. And then in the majority, almost 2/3, we have obvious drug paraphernalia, pipes, needles, drugs at the scene. This is usually not a big surprise when we get those tox results back. Next slide. Lots of questions about marijuana I get every year. 24% of all of the cases that come into the coroner's office test positive for marijuana. Now, you have to remember, that's not the general population. The people that end up in the coroner's office are not a randomly selected sample of our citizens. And so that number is going to be much higher than what the general use is. And we followed that number over time after legalization. It increased every year, maybe 0.5, maybe 1%, not dramatically. And then it kind of leveled out the last couple of years. However, this year represented a 3% increase. So it was a little bit of a jump, kind of similar to what we saw with all the drugs across the board. So marijuana is no different in that respect. And we talk a lot about opioids. We got to do something about opioids, and we're right. It's great. We do, and we have been working hard on it for more than a decade. In our latest round of opioid crisis, and if we want to do that, we got to look at what opiates are being used. And 86% of our opioid deaths were either heroin or fentanyl. There's not a lot of juice left to squeeze out of the prescription opioid reduction, right? We got it all the way down to single digits, right? That's where we need to focus our energies at this point if we're going to make a difference. And then if you throw the suicides in there, we've got 118 total opioid-related deaths. Next slide. So our suicides, lots. I think that was kind of at the forefront of many of our minds during the pandemic, and we all knew the impact it made on our own lives and the lives of the people we cared about and the community. And so, and this community has had its struggles historically with suicide, both in our youth and in our adults. The entire Rocky Mountain region, up and down, struggles with this. And so it's something that we were monitoring kind of in real time at my office. That's a little bit of a good news, bad news. The good news is that we finished at 178, which the year before in 2019, we're at 180. So we did not see an increase in our total numbers of suicides during the pandemic. And that's something to be celebrated in a way, right? Considering what we've all been through. The bad news is that 180 is one of the highest years we've ever had. So we're kind of equal with our worst, which isn't great. But it's something. And then the kind of the other bad news is when we get to kids that we did struggle mightily, as we have in the past with our kids this year. And that's a breakdown of lethal means, and we're going to talk quite a bit about that here in a little bit. But that's a breakdown of what folks are using. And so when we talk about means restriction, and safety, you got to look at what people are using and focus the efforts there. Next slide. Here's some stats. 42 is the average age. We had a range from 11 to 100 years. So this impacts every single demographic nearly that exists other than our tiniest of citizens. About 20% of the time, notes or social media posts, and that's evolved from, when I started out in my career, it was all handwritten notes. Now, oftentimes that's the intervention point. Social media, they start posting things that seem a little off, that seem a little worrisome, that seem out of character, that seem kind of desperate, and that's the point at which family, friends can intervene and make a difference, save somebody's life. 61% have reported a history of prior suicidal thoughts, so they are known to have these challenges. But that means 40% of the time, it's a relative surprise to their friends and families that they were struggling with these things. 3/4 of the time, we're going to find drugs or alcohol on board, and that's historically kind of consistent. And then about 20% have active or prior military duty. And so lots of efforts. There's been a lot of movement here in the last year or two of a little bit more of a collaborative effort and relationship with our military partners. We know what a great role that they play and what an important role they play in this community in particular. And it's critical that we do partner with them to get these folks the help that they need and deserve, honestly. Yeah.
Yeah, Dr. Kelly, do you have the breakdown of police force, our peace officers in suicide by any chance?
I don't. That's a great question. We do know nationally that first responders, law enforcement, those folks do have higher rates of suicide than the general population. And so that is an area that, I know our sheriff has focused on. He has a full-time psychologist on his staff. And so that's something that, we need to take care of the people who take care of us. And then one of the things we did follow was COVID related. And so what we do when we do an investigation, we talk to the family, we go through everything we can get access to about this person. And we identified 18 cases where they had specifically voiced that COVID-related stress, whether that was grief over the death of a loved one to COVID, whether that was economic factors or fear for the future or any of those things played a role, which obviously I think you would agree is probably an undercount too. We don't have the opportunity to have a conversation with the person, right? They're deceased, and so we have to kind of piece it together after the fact. This is true year after year after year, but I think, but I keep saying it because I think it's startling to most that don't know. It's that 79% of our completed suicides were male, and when we look at the age, it's middle-aged to young adult males, and so once again, we have limited resources, and so where are we going to focus? We're going to focus on the places we have the biggest problem and we can make the biggest impact. That has been an incredibly difficult demographic to reach, and that's why they have essentially an 80% account for 80% of them. But the hardest group to get to admit they have to to acknowledge that there's a challenge, the hardest to get to accept the help that they need, and then continue through that. And so much of our efforts at public health and some of the other nonprofits around the community, and if I had to answer this, I'd have a Nobel Prize. So I don't. But just because we haven't figured it out yet doesn't mean we don't keep trying. And so you'll see many of our efforts to try to find unorthodox or new or different or ways that we can reach that group that haven't been successful in the past. And so we'll continue to do that. Next slide.
Dr. Kelly, my experience dealing with other males is that they frequently don't want to talk about health issues. They keep it to themselves. They just, as a group, and maybe I'm generalizing, but from my experience, even males that are, have surgery that's recommended or other medical care tend to not take that advice. And if they're depressed, they don't use that word. Mm-hmm. And, the mental health issues seem to be buried. Is your experience similar to that?
That is my experience. And I'm also, this is coming from, I shouldn't admit this on live television, but I don't think I've seen my primary care doctor in probably like 3 or 4 years. So I'm just as bad as anybody else. I'm just thinking, you know what, you're right. I need to go see. It's been a long time. Give that cholesterol check. No, you're exactly right. You're exactly right. And there's only, that has to be a culture change, right? And we've talked about that a lot. In that, if you got a sprained ankle, you tear an ACL, nobody's going to shame you for going to see somebody to get that fixed. We need to approach mental health and mental wellness. And that's the other piece, is we've always approached mental health as it's either you're fine or it's broken, right? You're good or you're in a crisis. And that's not how anything works. That's not how our heart health works. That's not how our lung health works. It's a spectrum. You have to do the things up front to make sure you're caring for those organs so that you are healthy and strong. You got to get the exercise. You got to eat good. You got to do all the things. The brain and your emotional well-being is no different. That needs to be as much of your regimen of well-being and fitness as your biceps that you love to work in your chest, which you do upper body days, right? It all has to be one and the same, and it can't start at 50 or 60 years old. It has to start from the day that they're born. All right, next. Homicides. So when we talk about homicides, generally it's in the, where was the shooting? Who did they arrest? The trial comes and were they found guilty or not? And that's appropriate. That's how our criminal justice system works. But if you're from our perspective, you want to prevent them from happening, right? You want to get there before these issues develop. And so when you take a much broader meta look at what's going on and you look at the circumstances of the homicides, we see that the vast majority aren't kind of what we think in our heads about what homicides are, robberies and gang shootings and all these kinds of things, but that in this community, the vast majority are altercations, meaning two guys get in a fight, they get in an argument for, I'm sure, something, it's never like, how are we going to get peace in the Middle East? It's some idiotic thing that they escalate dramatically, typically to involve a firearm, that then results in people being killed. Or domestic family violence, meaning intimate partners, family members, people who you know and love and have spent much of your time with. And so when you look at both of those categories, what's the underlying issue there? And the underlying issue in the vast majority is usually young men who don't have the emotional tools to handle what the rest of us would perceive as normal stress. We all get in arguments with people. We all disagree with our partners about things. But these folks don't have the capacity, for a multitude of reasons, to deal with those things in a healthy, positive, productive way. And things spiral out of control quickly. And that's what we see nearly every day. Certainly several times a week at the coroner's office. And that's highlighted in that bottom. 53% of the decedents personally knew their suspects in their death. So they knew the person. It's their It's their spouse, it's their friend, it's their, somebody they work with or whatever. And we see that play out, unfortunately, many, many, many times. Next slide. So firearms related, I get questions every year from policymakers, lawmakers, folks like you, community partners. And so this report grows every year because people ask amazing questions. And I think I haven't really laid it out like that. And so this is where one of those came from. And so we look, we see on the news, we talk about mass shootings and all these kinds of things. And we talk about the homicides. But when we talk about firearms, that's not the vast majority of how situations where people are dying from firearms. It's suicides. It has been for a very, very long time. And so the question is, how do we deal with that? And one of my core values is it doesn't do me any good to autopsy people if I'm not gonna do anything with that information. The person who's deceased doesn't care. It's irrelevant to them. We don't do it for them. We do it for us, because from that drives how we're going to make our lives better and future generations better. And so we partner with a lot of the community. And my job is to deliver this information to people way smarter than me who can help figure out what to do with it. And so one of those groups is the Firearms Safety Working Group, which Dr. Wallace from UC Health is here today with us. And from this data, we partnered Dr. Russell, who's my deputy chief, is on the working group. And they do an amazing stuff, and it's a very diverse group, and he's here to answer any questions. But from this data, they have developed a 3-minute video, which I think we're going to show here today.
Time to transition Texas a little bit of time. Dr. Kelly, while we're waiting to look at the video, the 21 numbers, 2021, more optimistic?
Yeah, so for suicides, we're essentially on pace with last year. One of the things that we were supposed to be doing right before COVID was partnering with public health to come up with data dashboards that could kind of give real-time statistics. And then this whole pandemic thing happened, which really put a cramp on what we're working on. So we're hoping that once things start to settle down the second half of the year and next year, that I'll have the opportunity to have much more up-to-date statistics with some of these questions. But thus far, there hasn't been a significant change. No, we're essentially on par with last year across the board.
Okay, looks like we got the video queued up.
Gun ownership, whether it be for protection, hunting, or sport, is part of our culture here in El Paso County.
We are proud to live and serve in this community where so many active duty military, first responders, and veterans protect our American values.
We support and protect your Second Amendment right to own firearms.
While we live in one of the best cities in the country, we are sad to know that too many people in our community are dying by suicide.
In fact, more residents die by suicide involving a firearm than from homicides and motor vehicle accidents combined. In addition, more people die by suicide using firearms than all other suicide methods combined.
Suicide is often a result of a temporary crisis, and once it passes, you or your loved one's risk of death by suicide drops dramatically. And a firearm is far more deadly than any other method used to attempt suicide.
Many people believe when someone who wants to die because of suicide will do so regardless whether or not they have access to a firearm.
The truth is, 90% of people who survive a suicide attempt do not go on to die by suicide later in life.
In other words, people are much more likely to survive a suicide attempt if they do not have access to a firearm while in crisis.
The good news is that there are ways to protect your family. Suicide is preventable. As a community, we all have a responsibility to care for one another.
Do you know someone who is struggling?
Feeling hopeless, trapped, or in physical or emotional pain?
Are they increasing their alcohol or drug use?
If so, express your concern and ask directly if they're thinking about suicide.
Asking won't put the idea in their head. Listening to them and accepting their feelings without judgment can save their life. That might be all it takes to get them to the next steps of help and support.
Having conversations with your friends and loved ones about suicide includes talking about safe firearm storage.
Gun ownership, whether it be for protection or for sport, is your right as a citizen. With that comes responsibilities. It's our job to protect this community. We need your help.
Help us ensure the safety of your loved ones by storing firearms in a gun safe, keeping them locked, or storing them voluntarily and temporarily outside the home.
Remember, there is always hope. It's our duty as a community and citizens to help the people and each other that are struggling to find the light and find the hope. The following suicide prevention resources are available in our community. On behalf of all the first responders, we thank you.
Can we put that on our website as a link, please? If it's
Can we do that, Emily? Yep. Okay.
awesome.
Good
video.
question. Dr. Kelly, back to you.
All right, back to me. I don't know what the next slide is, but I'm sure it's riveting, whatever. Yeah, I can't beat that. All right, so one of the things we're also obviously responsible for is investigating child deaths. 2014 state bill passed that mandated local review of all child deaths. It was being done at the state. At the time, I was on the state child fatality review team, and so I supported this move, which then necessitated myself, and public health partners developing a local review team, and that's been going on now for a long time. The good news was that team came together right kind of when we needed them most. That was when our teen suicides escalated fairly dramatically, and so we had the right people in the right place to get moving on that as quickly as possible. That team continues through today. My deputy chief represents our office on that team now, but we have two of the folks who run that team with us today, and they're going to speak in more detail about what efforts have been going on at public health to reduce these. And these are emotionally difficult cases. These are our youngest citizens. All of these are preventable deaths, and so I think all of us would agree that we exhaust all efforts to prevent these horrible things from happening to kids in the future. And so when we look at what's going on, there was really two big age groups that we see overrepresented, and that's that 1 month to 1 year. This is overwhelmingly unsafe sleep deaths, and you can see that there were 8. 4 of them were unsafe sleep surface, 2 of them were bed sharing with adults, and 2 of them were both unsafe sleep and bed sharing. And this can be solved with essentially good education and good decision making by parents. And we, for those of us who have our parents and have young people, when you're tired and you haven't slept in days, you make sometimes bad decisions. And so it's staying on it for every new generation of parents, education on safe sleep to prevent these deaths. And then the other one is that 13 to 17. The biggest group of those are going to be our teen suicides. And that's on the next slide, I believe.
Dr. Kelly, before you leave that, what exactly are we talking about when we say an unsafe sleep?
Yeah, so the American Academy of Pediatrics has an outline of all the criteria you need to meet to be a safe sleep environment. And I could spend an entire hour talking about the evolution of SIDS and where we are now and the public health efforts that have gone into that and how effective they are and the dramatic reduction. The bottom line is that what we used to call SIDS was crib death. Babies went to bed, you put them in to sleep, and then they didn't wake up. And we learned starting in about the early 90s that when you really looked at those kids, you discovered that almost, not quite, but close to 100% of those kids were put to sleep in environments where there were certain themes that always came out, which is typically a young child, less than a year, sleeping on an adult sleep surface, a bed with other adults, or placed on a couch, an unsafe sleep surface where they can roll and then get wedged in the corner, or sleeping on a floor with mattresses that the baby can kind of roll and fall in between. So any sleep surface that does not meet those standard criteria, which is essentially hard, approved surface, no bumpers, no pets, no, adult bedding, no other humans sleeping on that same surface. If you do all of those, the likelihood of infant death approaches zero. It's not entirely zero, but it certainly approaches it. And that if you don't, the risk of death, if you do have any of those things, goes up. And so much of it is what we've been doing for a couple decades, which is back to sleep in a crib by themselves. And invariably the cases that we see, those that you see there, none of those met the criteria. And you can get those on, American Academy of Pediatrics, talk to your doctor, you can call public health, any of those places, resources online of what that safe sleep environment looks like. And then moving on to our suicides, you see there very, very strong male distribution last year, ages 11 to 17. The state defines youth suicides as 17 years 364 days. So once you're 18, you go into the adult category, which is why we keep the tabulation that way. A couple of things that changed. Generally, year after year, almost all teen suicides are limited to the school semesters. We very rarely see them in the summertime. But I think because of the dramatic disruption in all of our lives, and particularly youth's lives, last year it was almost an even distribution across the year in those deaths. I am happy to report that we have dramatically decreased those as a community this year. And despite having a very difficult year last year, I think within the last couple of weeks we were at 2, which is still too many. There's no doubt about it, but that's an improvement. So I think it's a lot of those efforts that we put in place, a lot of those resources, a lot of that community coming together, and with all those youth-facing organizations, hopefully is allowing us to weather this storm and get through it as quickly as possible. Next slide. And then homeless is another one that's evolved over the years. There's a lot on this slide.
Yeah, Dr. Kelly, Yolanda Avila's got a question for you.
Absolutely.
Thanks, President Scorman. No, Strand. Please do. Dr. Kelly, on the teen suicide, do you have any stats that go along with the LGBTQ community? I'm saying that wrong.
Yes. So we do. That is one of the areas that we investigate. We have a tool that we use that's essentially a survey that we ask family, friends, and what we know about the child's schools. And that is one of the areas that we track. I do not know off the top of my head what those numbers look like, but I've got 2 people that are coming up next who may be able to answer that question.
Thank you.
You are welcome. So this is our homeless deaths. It increased a little bit from the year before. That's probably a reflection of my office doing a better job of identifying those who are homeless. We use a pretty broad net to try to capture, and you can see the definition that we use up there, because homelessness, as we all know, is often, there are folks who've lived on the streets for years, but the large portion are kind of in and out of homelessness. They may have a hotel for a while, they may be sleeping at friends, they may have an intimate partner that they're living with, and then they transition in and out of that. So I felt that the best way to really capture what was going on was to just have that sort of broadest definition as possible. And that's kind of evolved over the last couple of years. And so the increase likely reflects that as opposed to true increases in the total number of homeless people who have died. I'm just getting better at finding them. And then you can see the breakdowns of the various categories. Drug substance abuse, we know, is a big issue of our homeless population. Mental illness with them is a big issue. But they also suffer from the natural diseases that the rest of us do. They just often don't have access to the same level of care and prevention and all those kinds of things that the rest of us enjoy. So all of that is going to take a toll on our homeless population. Next slide. And then I'll finish on this one. Like I said, it's one of the few positive things I get to do. 29 folks, El Paso County citizens, had organs recovered for transplantation, and 77 of those organs went into people and saved their lives. So continue if people are out there and trying to make that decision. That's a wonderful thing to make something really great out of something really, really horrible. So it's an area where our citizens routinely step up and do the right thing. I think
Dawn, did you have a question?
I do.
Yeah.
Also, I was thinking, do people donate their bodies to science? Does that go through you, or is that like set before?
Yeah, so if you die and you're under the coroner's jurisdiction, I investigate it, then once we're complete with our exam, we will release the remains to whatever funeral home or funeral service or to a research institute at your request. Whoever you decide, and your next of kin decide, we will release them to that person. I can tell you not a lot of folks do that. Usually that decision is often driven by lack of funds, maybe to pay for services and things, because those groups will generally then cover the costs of a cremation or whatever it is that they're going to do. But that's not a very common thing. For folks who have unclaimed remains, meaning they've died, they either don't have next of kin or living relatives, or the relatives don't want anything to do with them, which you have to understand that a lot of the folks who end up at the coroner's office, substance abuse, mental illness, they've hurt the people in their lives. And so it's not uncommon for those family members to be like, look, I'm done, I'm out. I don't want anything to do with this. In that case, what we do is we turn those remains over to the public administrator. We have a contract with a private attorney who manages those estates and works with local funeral homes to liquidate what property they have, to then pay off any debts and get those remains out of our office and into usually cremation, and then appropriately and respectfully placed.
Do you happen to know the percentage of people who do donate their organs to organ donation?
No, it's a very complicated process. So you say yes, I do, but it depends on, there's two things, either organs or tissue. And organs are what we commonly think of. You are in a motorcycle crash, you're brain dead, you're at the hospital, you're alive. Those are the organs that are going to harvest and then transplant into a living person. But the majority of people who donate don't die in a circumstance that makes that appropriate, right? They're dead, they've been dead too long, they're found too late. They have diseases or infectious diseases or other things that don't allow those organs to be transplanted. In those cases, though, they can take tissue like bone and skin and tendons and things and still use them in medical scenarios, often also in research scenarios. And so a lot goes into if something happens to you, where you end up in that. You make a simple decision, yes or no, do I want to? But after that comes many difficult decisions. And so I don't have a percentage, no.
Let me ask, I think many of us know that on our driver's license, we can make the decision that we want to be organ donors. And again, as you said, it may or may not be appropriate whether or not we passed and how long we passed and what our physical condition is. If we don't have it on our driver's license, can our family members make that decision on our behalf? Yes.
So if you don't make that decision on your own, and you are in a circumstance where you would be an appropriate donor, typically Donor Alliance, who's the agency, has a registry of everyone who said yes. And And that may be a situation where they may approach your family. I don't exactly know how my job is just to say yes or no. Will I let them or will I not? But that may be something that gets approached by the caring physicians and then Donor Alliance. And ultimately, the family still has the power to say yes or no. So you may say yes, but your family may say no.
Yep.
That's why it's important for you to have those conversations with
Your family.
before, so that they can hopefully honor your wishes. Because at the time they're worried about other stuff, right? And they may not be in an emotional place, but if they remember having that conversation with you, it makes it an easy yes.
And what organs can be transplanted?
Hearts, lungs, kidneys, certainly those are the big ones. But they can use, like I said, bone for grafts. They can use heart valves for other children who have congenital abnormalities. They can use skin for burn patients. There's not every organ, but the vast majority of organs and tissues have value to living people. And so it can make, and you got to understand that you say, well, I'm going to give my organs, and somebody gets your heart, and you kind of think, oh, I'm going to give my heart and I'm going to save someone's life. That's wonderful. That's true. But you may have dozens of people who are positively impacted, burn patients and little kids and house fires and scientific research that may benefit tens of thousands of people down the line. And so it really is an incredible gift.
Okay, thank you.
Did you say this is your last slide, Doctor?
I think it is.
Okay, so
Yeah.
So I'm going to talk about that, but I'm also going to talk about a couple other things, then, if that's okay. So your point was made, I think, the fact that the 27 who did provide some of those organs, 70 affected directly 77 people.
Exactly.
And of course, then there's the indirect effect on their family members and everybody else. In many cases, pretty direct effect.
Yeah.
So I think that's illustrative. And so I'm engaged in a little bit of advocacy, and please be an organ donor and have that conversation, because the fact that you can affect lives even after you may pass on is pretty huge. And yeah, science is great. You know, my wife has a metal knee of some thing, but not everything. We have not managed to recreate everything.
That's exactly right.
Let me comment. This is the third time I've heard the presentation. Councilmember Hingham and I heard you with the Health Foundation, but I also saw it online for the Paso County Commission. And I have to say that each time I learn things. And but I want to make a point that you started by talking about coroners, and I've been in other counties when they're having their elections, and the coroner candidates talk about how well they will do in notifying the family members and the compassion they will share. And that's kind of what they run on, because almost all of them are going to turn to an actual forensic pathologist for all of the main work of the office. And so that's what differentiates them. And we have always been blessed since I've been here to have a forensic pathologist as our coroner. We've had a series of them. I think one of the mayor's best speeches he's ever given was a nomination for Dave Bowerman about the top 10 reasons to vote for him, like never had a patient complaint, and a series of other things along that line. But we are fortunate, and I appreciate it. And it is, there are offices in which you select people mostly for the policies they're going to adopt, and there are offices for which you want someone who's competent. Ideally, you'd have both, but let me just say that the coroner's office is one of those that I care much more about the competence, and to my 91,000 friends who said I'd rather have a diesel mechanic as coroner, I disagree with you, and I think it is critical we have that forensic pathologist. But Dr. Kelly, you have done way more than just be the coroner, and so I know I've said this before, but I mean it. Your stepping in to help the Department of Health played a huge role. And I still believe that of all the briefings I've heard on COVID and related issues, you and your team that you work with provided by far better briefings than I saw on any of the network TVs and any of the folks in DC. And so we have been very fortunate and blessed to have you as our coroner. So now, having said that, now I've got another question. So you said 24% of all people who come into your office had evidence of marijuana usage. What's the percentage of those that died from an accidental drug death?
I don't remember if I have that. I have those for motorcycles. I have those for cars. I don't know if I have the presence of marijuana also in the setting. I have it on a spreadsheet, but I don't know if I know that number at the top of my head. It's going to be way higher than that 24%, right? Because that includes babies, that includes 100-year-olds, that's everybody. So it's going to be a higher percentage certainly than that what we saw there.
Okay. If it would be possible at some point, if you could just shoot us over with all of those other categories.
Yeah, and most of them are in the report. The challenge, and this gets into the pharmacology of marijuana, which I don't have time for, but there's limits to what I can conclude just because marijuana or metabolites are present. So what we've discovered is that marijuana is held on by fat, and when death occurs, the body begins to break down. And as the body breaks down, it releases those substances back into the bloodstream. And so after death, I draw blood, I test it, I have marijuana, parent and the various metabolites. Some of those are pharmacologically active, some of those aren't. And so ideally what you'd want to be able to conclude whether the person was intoxicated at the time. But because we are aware of what we call postmortem release, particularly in things like a car crash where tissue is crushed, or bodies that are starting to break down through decomposition, that we've done serial collections where you take blood today, you wait 12 hours, you take blood again, and there are differences in the blood levels that go up. Sometimes they go up, sometimes they go down. It's kind of, it's disconcerting in our ability to interpret those. All I can say when I take the stand and testify is that I have marijuana metabolites present in blood or body fluids. That means the person was exposed to marijuana recently. I can't conclude that they were necessarily intoxicated at the time of their death because of the various things that I just talked about. So, there's data, and then there's knowing what the data means. And we're in an area with marijuana where it's just, as we all know, it's just difficult. There's more questions than there are answers, but hopefully it'll evolve and we'll learn more. I can get you that, yeah. Thank you for your kind words.
So go see your doctor and take care of yourself.
I know. I knew I shouldn't have said that. That's so dishonest, being like, you need to take better care of yourself. And
I hear you. We appreciate your forthright.
Yes, I'll lead through a humility and recognizing my own failures.
Okay, Yolanda.
So, Dr. Kelly, I have the same sentiments about you as Wayne expressed. And maybe this will be reported on or presented by one of the other speakers, but like the LGBTQ community and suicide or death by suicide. You began the presentation with that in 100 years, our lifespan has doubled. And why is that important? And so here in Colorado Springs, people wanted to debate the number, whether it's 17, 16, 15, that our lifespan in Southeast Colorado Springs is that much less. It's double digits, however, and very disturbing. And so I'm wondering if someone is going to speak to that, because it's crucial, and how the zip codes 80916 and 80910 have been very impacted. They were impacted before, and now with COVID. So is anybody going to speak to that?
I have spoken to that on other occasions. I gave a whole speech to it last year. I don't have that data. Once we get to rates and those kinds of things, I usually leave it to my public health colleagues, and I don't remember. You guys don't have that. So we're going to focus on, I think, child fatality review and that kind of thing. But maybe I'll take that back to Susan, and maybe we can bring that presentation another time, because you're absolutely right. And we see that across the country. The zip code that you were born and lived in can alter your life expectancy upwards of 30 years from some parts of New York to other neighborhoods in New York. And that's also true of El Paso County, that depending on the neighborhood you were born in, your life expectancy can change dramatically. And as you said, 15 to 20 years in some cases. And so I don't know that we're presenting that today, but it certainly could be in the future.
Okay, I just think it's key when we're talking about lifespans and your work and determining what it is that takes people's lives. It's so crucial.
Yep, you're absolutely right.
So thank you.
Okay, any other questions of Dr. Kelly? Seeing anybody online? Okay, what's next?
So we've got my colleagues and Dr. Johnson. I will move and they can take these two.
Okay, Dr. Johnson, I got a question from Mr. Murray over the weekend about and it kind of gets off of the subject that Dr. Kelly talked about, but could you comment from the public health perspective on this Delta variant for COVID that, at least he and others have questions about?
Absolutely. So one of the things that we know and have spoken about throughout the year is just that public health preventive measures, right? And so we have right now in our toolbox the most powerful preventive measure, which is our vaccine, and that is still available. I think the important thing about this COVID virus is that we recognize that when it has a chance to infect people, it has a chance to evolve and find a better niche, right? And that's how we've been coming up with these variants. And the variants tend to look for ways to be more transmissible. And then we've been tracking to see if there is increased severity. And there are the variants of concern. And Delta is the most recent one that has popped up. It came originally out of India and now is in America, and we see it here in El Paso County. It is more transmissible. We are still really understanding the severity rates and fatality related to that. What is really important to understand is that it is still, the vaccines that we have are still efficacious against the Delta variant. And so knowing that it's more transmissible, we need to, particularly if you are unvaccinated, you need to still take the precautions. We know that we still have this, we talked about going from pandemic to endemic, means the virus was new and evolving through our communities. It is now in that endemic phase. We have numbers that are smoldering in the background. The virus is still here. We still see that there are cases and hospitalizations related to that. So if you're choosing not to get vaccinated, you really still need to practice those layered preventive measures that we talked about. And it is not mandated any longer, but keeping your social distance, really being careful about numbers and locations that you are engaging, and wearing a mask, good hand washing. Outdoors is always better than in, right? These are the things that should just kind of be a mantra. But in lieu of that, our best measure is still that vaccine. And so if you have the opportunity to get vaccinated, it is widely available, it is disseminating now from our more mass vaccines into just being with your primary care provider. You can go to elpasocountyhealth.org and look underneath our little vaccine tab and see how you can connect yourself to a vaccine and join in protecting yourself, protecting your neighbor from being able to transmit it, and then ultimately protecting our community for the impact that we want, which is to interact back to as normal as possible.
Yep. Thanks, Dr. Johnson. Any
Absolutely.
questions for her about that? Yeah, go ahead, Richard.
Yeah, Dr. Johnson, so, the big question for a lot of the people in my world is that the people who are vaccinated, can they still give the Delta virus to somebody who isn't or is extra vulnerable? So, we have, people with chronic diseases, are working in our complex. We have a few people that aren't vaccinated, and that seems to be the real confusing question. I see you're not wearing a mask right now, and nobody is from the health department, and yet you hear about Los Angeles recommending masks because of the Delta variant and the World Health Organization. And I wonder what your advice was. It's a tough one for those of us who are vaccinated that want to be out in the world, but we also wouldn't want to, bring it back to somebody that is vulnerable.
Absolutely, and I think that is some of why healthcare still has an art to it, because some of these things are fairly nuanced. And so when we talk about the efficacy of a vaccine, when you're vaccinated, it's not like 100% that you're not going to contract the infection. It depends on how many people around you are vaccinated. And so you hear that term herd immunity, because you're breaking the chain of transmission. It depends on how good your own immune response was to that. And so for some people who may be on some of the biologics, let's say for an autoimmune disease or something, their immune response may be muted. And so even though we would want them to get vaccinated and their primary care would ask them to be vaccinated, they still may be wearing a mask, because that is that layered approach of preventive health. And so when we talk about being vaccinated, and I am vaccinated, which is why I've taken my mask off, but I certainly carry a mask with me so that if I know I'm in a situation where people are unvaccinated or they have concerns and would like me to wear a mask, I can respectfully put that right back on. Because again, it's a preventive measure. I think as far as contracting the infection, there still is a small chance of being able to contract the infection. The severity of disease in those who are vaccinated is significantly less than if you are unvaccinated. And we are following that with Delta, again, gathering data around that severity and potential fatality. But we haven't, the other thing is when you contract it, if you've been vaccinated, your viral load is significantly less. So the ability for you to actually transmit it drops significantly. And so part of what we talk about when you get an infection is inoculation. And so how much virus are you exposed to? It's very different if your body sees one little virus particle versus 100 versus 1,000. Which again is why we talked about limiting group size, right? If you're exposed to, over a day, one person who's sick versus 100 people who are sick, your likelihood and probability of actually contracting the infection is very different.
Okay, and then one more question, if I can.
Go ahead, Richard.
So how are we doing here with vaccinations? And let me qualify this question a little bit. I know that we have a little bit low. We have a lower rate than the rest of the state. We also have a lot of tourists here from states that may not have a high vaccination rate. And we also don't know. I don't know if we're really tracking the military as part of these numbers. I know you certainly track, through all the health providers and everything else, but I just wonder if you could give me a little summary of how we are doing and where we need to go.
So I haven't looked at those numbers today, but we have a data dashboard on the El Paso County Health.org, and they are following the vaccination rates. So you can look at those, and those are updated I want to say at least weekly. The vaccination rate in El Paso County is over 50% fully vaccinated. So that's 2 doses. And what we do know, particularly with the Delta variant, is that you want to get that second dose. It's going to be really important. And we have a high rate of people completing their vaccine series, which is really, I think, one of the strongholds of El Paso County is that people get that second dose, because that truly is the key to success, is getting the complete series. We do have a data agreement with our federal partners here in the county. It has been a challenge, I think, across the nation to actually get those numbers because their jurisdiction is different. If you're vaccinated through the county, it's entered in the Colorado Immunization System, CIS, and we can pull those numbers. If you're vaccinated through the federal, it's a different documentation system, and those numbers are not necessarily shared easily. But we have figured out a way to do that through our data and analytics office, and we are over 60% vaccinated when we include those federal numbers. And so it is a slow tick upward, but we are making progress. And again, it is really about having the opportunity to engage with people, talk about where they are in their own sense of why or why not to get vaccinated, answering questions, alleviating fears, and then hopefully changing the paradigm into that this is the norm, that we just do get vaccinated because it's preventive. It protects me, protects our families, and it protects our community.
Thank you. We had several other questions, but I've got a community member who texted this to me and wanted me to ask, is there any plan for the El Paso County Public Health to have volunteers go door to door to check on vaccination status?
I'm not aware that there's a plan to do that, and but certainly we are open to new and innovative ideas and reaching out to people wherever they are to hopefully, just meet them with an opportunity to learn and step into the next phase.
Okay, we'll go to Randy and then Nancy.
First, thank you, Dr. Johnson, for everything you and your organization is doing, the office is doing. I saw that on Saturday when we had the Olympic and Paralympic Day in Deerfield Park. The mobile vaccination unit was there. And after talking to them, I didn't think anybody would come up, but they did. They said they had several people come up and get their first vaccination. And so I think it's so important that we're out there in every way possible. And I just wanted to thank you for that.
Thank you.
Nancy?
Yeah, what's the age, how low now can you go in age for inoculation?
How low can you go? Sounds like we're going to do the Mamba. 16. There is ongoing research being done, and we're hoping that we'll be, dropping that age as we enter into the school year, but more information to come.
I forgot to, Richard asked a question about the military here. I can't speak for Fort Carson or Schriever or Peterson, but I can speak for the Air Force Academy. Being involved in that up there, as of late spring, the cadets, the over 4,000 cadets, more than 90% had been vaccinated in late spring, and that's probably even grown through the summer. So just to answer Richard's question.
Thank you.
With the presentation, that'd be great.
Sure. Good morning, everyone. My name is Megan Haynes. I'm public health planner for El Paso County Public Health. And I'm joined by my colleague, Kelsey Leva, and we are going to take an opportunity to dig a little deeper around our youth suicide prevention efforts. So that's what Kelsey and I will be speaking to in the next couple of slides. So next slide, please. Want to provide just some additional data that wasn't captured as part of Dr. Kelly's presentation. This is Healthy Kids Colorado survey data for El Paso County. And what you see represented here on the slide are the suicide indicators that are part of that survey. That survey is administered to middle school and high school students in the county. It's done on an every other year basis. And so we have 3 years worth of data represented on this slide for the years 2013, 2017, and 2019. Starting from the far left, you see the numbers around attempted suicide one or more times in the past year. The middle section is made a plan about how to attempt suicide in the last year. And then on the far right there, seriously considered attempting suicide in the past year. The big takeaways from this slide are that 2019, which is our most recently available year of data, are the numbers trended very similarly to 2017 across these indicators. Our latest survey results indicated that roughly 1 in 5 young people seriously considered attempting suicide during the past year. 1 in 6 made a plan about how to attempt suicide. And then almost 1 in 10 attempted suicide at least one time in the past year.
That's shocking. Yeah.
I'm just going to jump in. Are you
No, go ahead.
going to move on?
Yeah.
One of the important things, and I'm making a promotion here for this survey. When we get to present with Dr. Kelly, he always has all the beautiful and sexy data slides, which I actually have a little data envy when he does that. But we in the preventive realm, or sometimes in healthcare, because of the way we have to aggregate data and protect people's privacy, it can be a little bit more difficult to really get a pulse on what's happening in our community. This survey is a beautiful opportunity for that to occur so that we can look upstream and say, before we get to the tip of the spear, which is, that fatality, what can we do up that, river to really begin to impact and understand what are the trends? What is happening in our culture? You'll see there was a blip here. We don't have any data from 2015. And we didn't have enough schools who had enrolled in this survey to have an appropriate data sampling. And so one of the things that I just want to really promote here is that we as a community really understand and support our schools in participating in this survey so that we have the information we need moving forward in these preventive efforts.
Tom.
Sure. Go ahead, David.
So what jumped out to me, Megan, was in the column on the left, the attempted suicides is pretty much doubled from, 13 to 19.
Yeah.
But then you mentioned something about, well, maybe, 1 year we didn't have enough schools to even get the data. So it's not always the same schools, like the one we see 5.3, there might be different schools involved in 9.7?
Correct. So the sampling looks different from each survey administration. It is a recruitment process in which the survey administrators work with local school districts to determine who will participate. There are some partners who remain consistent year to year because they value participation, they value having their own data to track through every iteration of the survey. But you're correct, the sample does change slightly from each survey administration.
Okay. And then perhaps this is what you're going to address in another slide, but what is your explanation for a doubling in attempted suicides in, 6 years? A 6-year period?
So
that's an easy question, I'm sure.
Right.
Yeah.
And my answer right away is that suicide is a very complex issue, obviously. We paint a fairly good picture of what we understand to be the case with our data, but it doesn't always capture some of those more complex underlying factors that could be driving suicide ideation, suicide attempt, suicide completion in our community. It's multi-factor in nature, and we'll get into a little bit some of the different efforts that we are working on in public health to address it from that standpoint of knowing that there are just a number of things that can impact this issue.
Do you have one or two that you think are the big ones? Hey, this is why we think it's doubled in 6 years?
Well, so I will tell you, I have been working in youth suicide prevention for a little over 5 years now, and the number has changed significantly over that 5-year period as well. So as Dr. Kelly referenced, when the Child Fatality Review Team began convening in 2014, we saw an increased incidence in youth suicide in 2015, 2016. But through our collective efforts as a community, we were really able to bring the rates down in 2017, 2018, 2019. Through our child fatality review process, we see a number of individual level factors that are impacting young people, family and social discord. They go through a lot of changes. They face a lot of difficulties and struggles in their home life, family life, perhaps in their school life. And then, young people are facing very significant issues in this past year with COVID and all of the stresses and challenges that come along with that. And so I can't point to exactly, even one or two factors. For each individual, their circumstances are going to be different, but they are often sharing some of those difficulties and having, tough times navigating those and finding the hope and resilience, although we're working very hard to build those protective factors around young people so that they don't see suicide as an option. For what is often a temporary crisis that once they navigate it, they go on to live a long and healthy life.
Mm-hmm. And this will be it for me, but if it's doubling, then it seems to me that something's getting worse, right? If you have twice as many children attempting suicide, the constant probably is, troubles in the family, things like that. But what is it that's causing it to double? What got worse over that 6-year period?
Right. And it's a very valid question, something that we're absolutely tracking through our work. Some other reflection on the data to perhaps consider is how far we've come as a community in terms of talking about this as an issue. So sometimes do we see an increased incidence in discussing making a plan or, attempting suicide or seriously considering suicide because we've made it more acceptable for young people to talk about that as something that they're dealing with and seeking help for that? Are we recording more incidences of that help seeking? And is that perhaps what is reflected in the data? That is just another factor that could be part of the picture, is worth considering as well, I think, especially when we're talking about these more discrete data points that don't often tell that full story.
Attempted suicide, is that a documented attempted suicide where they went to the ER or their parents walked in and, they were attempting a suicide? Or is that just a reported, on a piece of paper, yeah, I tried something, no one knew about it?
Right. So for the Healthy Kids Colorado survey in particular, that is self-report. So this would be young people who are taking the survey, self-reporting, having attempted suicide. Certainly suicide attempt that results in an emergency room visit or in a hospitalization is also tracked, and we do have access to that information. And that is something that we're tracking as well. But to your point, not every suicide attempt is so injurious that it requires medical attention. And so that's why we need survey tools like this. We need data from the hospital system. We need partners to come together to be sharing that information so that we paint that most accurate picture.
This really will be my last question.
Sure.
Were these surveys anonymous when the kids fill them out?
Yes. So this is a completely anonymous survey. It in the past has been pencil and paper. In the most recent iteration, they were moving to a computer-based application. So I believe in the next iteration as well, they'll have that ability. And so kind of upping that technology as we move on and hoping to have more young people engage in the process and inform our prevention strategies.
Thank you.
You're welcome. All right.
Okay,
Next slide.
Wayne, go ahead.
Yeah.
Can I just,
Thank you.
Wayne, did you tell us what the percentage of kids of this age who did take it was?
No, I did not. So we don't often get a report of the actual percentage of schools or number of students. We don't get a lot of information about the actual sample. All we know is that it has to meet a certain threshold of participation for us to get county level results like this. So to Dr. Johnson's point earlier, in 2015, the sample size wasn't large enough for it to be reported on a county level. All of that data for the schools that did participate in 2015 stayed at the school level. It was not enough to aggregate and roll up into a county level reporting.
Okay, Megan.
All right, so this next slide here digs a little deeper around the particular question of students who attempted suicide one or more times during the last year. The graph on the left is for data for the years 2013, 2017, and 2019 again, male and female. So you'll see that data represented there. And then on the right-hand side, Councilwoman Avila, to your point earlier about the LGBTQ community, we have data for those who identify as gay, lesbian, or bisexual, heterosexual, and then unsure. So those are a breakdown of the demographics around this attempt question.
So are there numbers and or percentages, because it doesn't do me any good to hear over there and over here and that.
Sure, yes, and I will get to that in just a moment. I will break that down for you. So this is all to say that disparities between males and females continued in 2019 compared to 2013 and 2017. Higher rates of suicide attempts among females than males. But we know, based on Dr. Kelly's presentation, that rates of death by suicide are higher in males. So perhaps this gives us some insight into a shift in the youth data. Either there's an increased lethality of means being utilized by young women, different diagnoses or factors at play underlying the suicidal ideation and attempt. And then we know that incredible disparities persist among youth who identify as gay, lesbian, or bisexual compared to youth who identify as heterosexual or unsure. In 2019, nearly 1 in 4 participants who identified as gay, lesbian, or bisexual reported attempting suicide 1 or more times in the past year, compared to 1 in 15 participants who identify as heterosexual. So that's a huge disparity that we have seen play out in the data year to year, and something that we are very concerned about as part of our efforts and wanting to ensure that we're aligning our resources appropriately, that they are culturally relevant and culturally responsive to the LGBTQ community as we support those young people.
Yep, correct.
Yeah, I just noticed that the opposite gender in youth from the adult statistics that Dr. Kelly showed us, at least in terms of attempts, more female than male, whereas completed suicides in adults is more male than female.
Yeah, well, and I think, so it's really important to recognize, we have seen that in the emergency room, so I practiced 24 years, that there are historically more attempts, but when men do attempt, they tend to use more lethal means. And so they tend to be more successful. And so to Dr. Kelly's point, that and Dr. Wallace around firearms, though access to those lethal means, restricting that and finding ways to protect people who are struggling, but also then intervening so that they have the opportunity to, speak about it rather than have that one fatal event, if we could avoid it.
All right, next slide, please.
Okay, go.
So we'd like to talk a little more now about the Youth Suicide Prevention Work Group. So that is our largest effort around youth suicide prevention. We've been convening and facilitating this work group since July of 2016. So we're coming up on 5 years of convening of that group. It takes collective action in support of youth mental health and suicide prevention. And it's grown to involve more than 90 different community partners from various sectors across the county. The work group has a steering committee that oversees and supports implementation of community-driven strategies to prevent youth suicide and really reflects the cross-sector collaboration that's necessary to address this complex issue. Partners involved in the work group and steering committee include youth serving organizations, school districts, behavioral health organizations, hospital systems, are nonprofits that address mental health and suicide prevention, and faith-based organizations, among others. And then I am going to go ahead and turn it over to Kelsey to talk a little bit more about our efforts.
Thanks, Kelsey. Welcome.
Thank you. I'm Kelsey Leva. I'm the Youth Health and Development Planner for El Paso County Public Health, and I've been working with Megan on this topic for several years. And if we could go to the next slide, please. Wanted to share with all of you a little bit about our efforts in 2020 and 2021 with the community and with our partners in this work group. In 2020, we were able to shift that work to a virtual space pretty quickly and continued to meet throughout the year, both with our steering committee and with our community partners. And they remained very dedicated and participated really fully throughout the year. In fact, even at some points increasing the frequency of our meetings because we were very concerned and focused on supporting young people during this challenging season of our lives during the pandemic. In 2021, we knew from our work with Dr. Kelly and the Child Fatality Review Team that we had seen an increase in the number of youth suicide deaths in the previous year. And so we took some time as a group to really reflect and understand to the best of our ability what young people were experiencing and how we should shift our work to better serve them. So at the very beginning of the year in January, we prioritized these suicide case reviews with our Child Fatality Review Team and accelerated the process. So what would normally be done towards the end of the year, the following year, we got done in the first quarter of the year with that team, meeting more often and making sure that we reviewed those cases thoroughly to then have information to share back with our partners in the Youth Suicide Prevention Work Group. So that was one thing we did. We also held a panel with young people from our community to hear from them directly about their experiences. After we did that listening and learning, and kind of concurrently with the case review process, we jumped into a new community gaps and needs assessment. We had previously done that when we first started the work group. It was time to reassess because the game had really changed and young people were experiencing some new things. So we completed that gaps and needs assessment process, and then we went kind of and prioritized them, which are the most important right now, and then what strengths do we have to address those gaps and needs, and where do we need to focus, and kind of, continue with that energy. April through May this year, we've been able to really dig into action. So instead of just, understanding the issue, now we're talking about a community action plan, and our partners are putting skin in the game around, this is what I'm going to do. This is what we're going to do. These are the goals we have together. So we have a new 2021 Youth Suicide Prevention Work Group Community Action Plan. And through the rest of this year, we'll be kind of checking in on that action plan and problem solving. And I want to share a couple of the things in that action plan just so that it's more tangible for all of you. We are working to increase the utilization of a universal release of information so that information sharing is happening among different agencies that serve youth in the community, be that schools or behavioral health or, anything like that. We are working on additional parent-led resources that are informed by local parents about this topic and how you can find help and where to go for that help, what to look for, things like that. And then we also have some really cool innovative partnerships with the faith community that are happening this year in our action plan around connecting youth to counseling services when they need them. Next slide, please. So wanted to take just a quick moment before we hand it off to Dr. Johnson in the next couple slides to share with all of you some ways that we can all be part of preventing suicide. It really is everyone's job to do this. And one of the first things that we can do is change the way that we talk about suicide and normalize seeking help and hope, telling those stories of hope and sharing our personal stories of challenge and elevating that in the media. Things like that are really helpful to shift the conversation from the contagion piece of suicide, and it's very concerning, it is, but we do need to tell those stories of resilience as well. We can also change our language when we talk about suicide and avoid using terminology like completed suicide or committed suicide, or referring to a suicide as successful or unsuccessful or a failed attempt, and instead shift our language to say this person died by suicide or they attempted suicide. And when we do that, we make ourselves more available for that conversation when someone is experiencing suicidality, or if they've lost a loved one to suicide. And so that's a shift in our language that we can all make, and happy to chat more with you about that if you have questions as you're preparing to speak to the community. And then we also encourage everyone to attend a gatekeeper training, just a short session on how to have that conversation with someone who is struggling. It's challenging in that moment to look at someone and ask that difficult question, and it's important to take time to learn how to do that and practice it. So we would recommend the Question, Persuade, Refer gatekeeper training. Next slide, please. And then last but not least, we want to share a few resources with you, because we know that you are in the community and hearing from people about this topic. It's something that has impacted us all very deeply. So we want to equip you with some resources that we find really helpful when having those conversations. The first three on this slide: the Protecting Youth from Suicide resource is a document written by parents, local parents, for parents. Beyond the Curve and Below the Surface are also resources that were informed by local youth. And these are very relevant to the current experience in our community in the last several years, and even in the last year. So these are great resources that are very locally driven that we would recommend you use when having those conversations in the community. Sure.
Quick question. So I believe, at least I know Councilmember Avila and myself received an email from the National Suicide Prevention and Action Month proclamation. Are you familiar with that group? They were inviting us to participate. It's a national organization, looked like a potential other resource, and we referred them to you. So.
Mm-hmm. Yeah, so we have participated in some local efforts that align with, proclamations around Suicide Prevention Awareness Month. It's usually in September, but that's something that we have done historically. We'd be happy to continue.
Yeah, it's called Hope for the Day.
Oh, okay, yeah.
Would you,
We are familiar with Hope for the Day.
Okay.
Yeah. Mm-hmm. Yeah. It's a good resource. It's always good to be opening that conversation about this issue in our community.
And apparently they partnered with Cerebus Brewing Company to do some work. So I think we sent them your way. I hope we
Okay.
did. Yeah.
Thank you. Thank you for doing that. I want to also remind everyone, Colorado Crisis Services is available 24/7 in Colorado. And you can access that by calling that number 1-844-493-8255, or you can text TALK to 38255. We also have a walk-in location here in Colorado Springs if you'd rather be in person. And
the walk-in location, what hours and days?
It's 24/7.
24/7. Okay.
Yes. Mm-hmm. And then the last thing we want to encourage all of you to do is, when you're having conversations in the community, or if you yourself are really passionate about this topic, we want to connect you to the Youth Suicide Prevention Work Group, and we want you to be involved. So just reach out to Public Health. We're happy to make that happen, and we encourage any new voices to come to the table and be part of this effort. So thank you.
Great. Thank you. Dr. Johnson?
Sure. So a couple other resources. So I turned it off so you wouldn't hear me breathe. A couple other resources. Our Youth Suicide Coalition is part of a broader consortium of suicide prevention that is headed through CHP. So we are looking at what is happening in the adult population, and particularly with the crisis more in our men than women. And so that has some additional resources. Plus, if you are with someone who is in a crisis, you can always call 911. We do have our community response team locally to Colorado Springs municipality area, and we have the Beacon unit, which is available throughout the county, and there is a unit that is specific for Fountain that has just started as well. And those have been incredibly successful in linking people, again, from a point of crisis to the resources that they need at the time. So right care, right time, right place. And we have data from those units if ever you're interested, because they've been tremendously impactful. Are we ready to move on to the next slide? So I have the opportunity having been in 24 years in the emergency room, to really understand that there's a litmus test about what is happening in our community, and to begin thinking about how we begin to move upstream from that. And we have begun a collective impact initiative around this behavioral health issue. It is the issue around our suicidality and depression, mental illness, but also it goes hand in hand with substance use disorder. And they tend to be travel partners because they play off of each other. A lot of our substance use is in treating some of our own mental health. Part of Dr. Kelly's presentation was that there's that polysubstance. We use not just one drug, we use multiple because we create cocktails to help us feel better over time. And yet our substance use also destabilizes our mental health. And so it accelerates some of those problems. This initiative came out of our justice system. It's been 2 years in the making, listening to stakeholders and multiple studies that were aligned purposefully so that we would get a continuum of understanding. It started in the jail, and then the CJCC brought to bear some more monies, and public health completed some of that study with utilizing HMA, Health Management Associates, as the consultant to bring this information together. And the goal is actually that what we would be doing here is taking the action items that you've heard from like the Youth Suicide Coalition, what's happening with CHP and more general, some of our treatment options, what we have with our fire department and the CARES navigation that they do, our crisis mobilization, right? We have these great programs. How do we integrate them? How do we weave a fabric of support that is accessible for the people who need it? Again, making sure that they have warm handoffs, and we begin actually moving the needle, the dial, into prevention and upstream so that they have smaller and smaller numbers showing up for Dr. Kelly to report out on. Next slide. So why do we want a collective impact? And part of this is it's really about community impact. There's several different terms that are used for this, but it's proven and it's a systematic approach. It allows us to transcend our silos, right? So we tend to do things within our agency, and this is actually building bridges between those agencies, cross-sector, cross-agency, that fosters collaboration and integrated solutions. They also are cost-effective, and they change the paradigm for future generations. It also creates some accountability so that we have not only vision, but we have a contribution, allocation of resources. And so it's kind of like the Thanksgiving dinner when you all are coming to the table and you go, hey, I've got the turkey, and over there, Councilwoman Hingham says, I've got green beans. And then we have Councilwoman Avila bring the stuffing. We finally will end up with a full meal, and that is what the collective impact model will allow us to do. It also lets us know what our partners are doing so that we can capitalize on using those resources. It identifies the gaps. Instead of saying, hey, that's your problem and we're going to toss that hot potato, we go, hey, this is our problem as a community. How are we going to resource that now that we know that we still need cranberry, for the dinner? We can reach over to Councilman Strand and say, hey, would you happen to have some cranberries, or would you know somebody who does, right? Next slide, please. Absolutely.
And this has to do with a little bit with the last speaker too. But what you said, Dr. Johnson, who was the last speaker? Because I want to remember her name. Kelsey. Thank you, Kelsey. So one thing that you said, Kelsey, was, we have to watch our language and around how we talk about it, right? But I'm wondering sometimes if people won't tell about their situation and how they're feeling because of if they do, what happens that when you do reach out and saying, hey, I want to kill myself or I want to die? And because there's nothing, are there consequences to doing that in terms of, is there documentation? Could it lead to hospitalization? Could it where there's and ultimately lead to maybe job loss or something like that? Because I'm thinking that that might be one of the reasons that people don't reach out. But I figured between the two of you, you would be able to answer.
Yeah, thank you for that comment. I think you make a really excellent point. There are definitely things like that that are consequences of reaching out that do keep people from speaking up. And we have heard that. Oh, okay. Scooch it forward. We have heard that several times over the years in this work. And certainly some of it can be addressed through addressing stigma in our community. And, you know, part of it, when we are speaking about suicide more, when we are telling our stories of resilience and hope, hopefully that addresses that stigma and opens up the door for people to speak out more openly. But there are also some systems pieces that are at play here around, you know, consequences. If something is in your file, it might affect your future job prospects or perhaps your military service if you go into the military and things like that. So we have heard those for sure, and they definitely are at play here in our community and in the country. And then in terms of you know, hospitalization and the impacts of that, it can be very stressful for sure on families and financially, and to go into that level of care. So that's part of why we would encourage you to take these classes, to be prepared to have those conversations when someone is in crisis or experiencing a moment of suicidality or struggling, because it coaches you on how to have that conversation in a way that leads them to, you know, taking that step with you to go get help, and to what is that next step and what does our safety plan look like. And so I really believe that taking the time to have that training is incredibly helpful, so that we're prepared for talking through and thinking through those consequences with people when they're in those moments of crisis.
Okay,
Yeah, and I would tag on to that to say that, you know, there are always one of our jobs is to really try to help people think through unintended consequences, right? I mean, when we initiate something, it can always happen. And one of the brilliant things that these ladies have done is to continue that conversation, and I've forgotten the initiative's name, but the sharing of information. So when they would come, these children come to my emergency room, I wouldn't necessarily get the documentation from the schools because there's a privacy issue with FERPA, and then we have HIPAA, and all of these kind of systems are in place to truly protect the individual, but the unintended consequences that we don't connect and weave together their care. And so this kind of sharing information has been a long time in the making. It has taken hundreds to maybe thousands of hours and commitments from school, first responders, providers to overcome some of those consequences so that we get the right care at the right time and in the right place, and give particularly our youth an opportunity to grow. I am certainly happy nobody, you know, pigeonholed me at the age of 15 when I was so shy and couldn't speak, that was who I was going to be, because then I wouldn't be here today, right? With the opportunity to grow and evolve and change and learn. And again, our mental health can be a crisis moment, and we should be able to help people step up above that and see hope to move beyond that without it being something that has to follow them throughout life as punitive. It actually is a moment of celebration because it is conquering. And so we are certainly working on all of that, but systems change is really difficult. And that's what this initiative is about, which is why we're presenting it to you, because it is going to end up having to be a public and a private sector integration. It's going to have a potential for legislation and advocacy and regulation that empowers the right actions to be taken. And so we're going to chart a course forward with this Behavioral Health Steering Committee, leveraging what we already have in place. The current assets, which include those crisis units, Beacon and CRT, as well as CARES, diversion programs that have been developed. We are focusing on some of the justice involved, but it's a continuum of care, because to really keep people, it's like keeping them out of the coroner's purview. We have to move upstream. One of the places that we know people have some of those long-term consequences, City Councilwoman Avia, that you spoke of, is if they end up in jail. And we are wanting to divert people who are struggling with perhaps mental health or struggling with substance use into the right care, and avoid some of these justice solutions that have been there in the past. So we'll leverage partnerships and strategies, creatively mobilize our resources across the system, and begin braiding them so that we weave this fabric of safety for our community and health. And then we need to address short and long-term behavioral health system goals. We need the short term because we need some answers today, but we also need hope that we're making a difference. But we have to understand that this is a paradigm that is an investment over time. I've been involved in this since 2012 when we acted on a white paper to begin CARES. And then from that came CRT, from that came Beacon. Out of CRT, we saw this rise in calls from our schools. And about the time that we began at the fire department to address that, along comes Megan, and they took the ball running with public health to really initiate the suicide prevention. And so it is, when I look back through my lens of the last decade, we are so far ahead and we have resources. And I think the iron is hot. It is time for us to act. So next. This is a critical focus that the steering committee will be able to do to really create some sustainable solutions along with those long-term goals. It'll be integrated. We're going to be data-driven. We have opportunities, and we'll speak to that. And it's consistent communication. If I can just say communication. What is the second solution? Communication. What is your third? Communication. The top three things is to really be talking to each other and know what the left and the right hand are doing so that we can end up bringing them in a strong solution. And then sufficient backbone support, and public health is stepping into this role. And again, it is not, the backbone is only a center part. It is only one part of the whole body. Next slide. So we will have that steering committee, which will act as governance to bring private and public sectors together, as well as our nonprofits and providers. But also we'll have these 6 work groups. And these is by no means the full of what is happening in the community, but it is, again, beginning that communication and integration of what has been happening. And we're looking at prevention, diversion, community and navigation, making sure that we assist people with reconnecting into the community for what they need. A re-entry, so this is the focus for Justice Involved to get connected and looking at those social determinants. I'm sorry, that's a typo on that slide, but those social determinants of health, which include, I think we've done a presentation on this, right? Some of it is zip code driven. It's that built environment, it's food security, it's employment, it's education, it is access to care, and those things that help us to have human flourishing. And then again, treatment, access, whether it's our peers who help us stay healthy because we have relationship, faith communities, behavioral health, and medical. And then data, which is one of those beautiful things. Again, with our data and analytics office, we will be able to begin bringing some of the data to bear that is more upstream and integrating with what are our trends, hopefully impacting that before we hear the final outcomes that are coming out of the coroner's office. And next slide. I would like to just open it to questions. I know that was kind of a quick, and if you need more background or have questions about where we hope to be going, now is a good time, and obviously always available for anytime you have questions for me.
Great. Anybody on Microsoft Teams with any questions for Dr. Johnson or Megan or Kelsey or Dr. Kelly? Hearing none. Anybody up here on the
I'd like
dais?
to shot.
Yep, go ahead. Is it Bill?
All right, real fast. Since you missed me at the last portion, I'm going to cover all the issues.
So this, Mr. Murray. Yep, go ahead, Bill.
Real fast. I've got concerns about contact tracing, the range of your testing, and of course the PSAs. If you need more money to help energize those projects, I haven't seen it, so I'm very concerned that we have an issue involved that. So please get back with us and tell us what you need, because I really don't believe we're doing enough as we watch the Delta variant spread. You know, and we, as I look at the Delta and I look at the numbers of folks who weren't vaccinated, and I look at your term collective impact approach and your healthy community collaborative, I see a clash in attitudes and concepts within the community. I think one of the speakers said it succinctly. We don't have a clean coping mechanism, okay, to assist us all in coping with the changes in our environment. All right, we have this consistent fight and flight thing. You see it every day with road rage, you know, and because there's no real structured coping mechanism, people just, you know, go into a corner and fight or flight. And it's all about motive and opportunity. The motive is, I got nothing to lose. Opportunity is, I have a weapon, I have drugs, or I have alcohol, which assists the rest of it. Okay, and where do they get those things from? From other community members, okay, who can't cope themselves with what is going on. So again, I recommend highly that you put a different piece on it that says, how do we teach people how to cope with circumstances, with changes? You know, I've been on so many stressful environments where people just come completely apart. And you're either part of the solution or you're part of the problem. So we removed the problem and tried to get the situation done. But I do believe you need more resources. And I haven't seen them, and I'd like to offer them. I think all of us would like to assist. But without a structured coping mechanism environment for the adults who are teaching the children, who are pushing the children away, without coping mechanism, like we had the other day with that poor child pulling the weapon out and shooting himself in the car, okay? Ladies and gentlemen, it's the adults here who are not learning the lesson, who are not coping well, okay, who are assisting the bigger problem we have. And I think we need to sit down, and I'm very fearful of friendly and familiar and happy, glad terms and not results. And I think this is where typically we miss the boat. And again, I think we really need to develop a coping mechanism project, okay, and stress it to the parents to try to get some of the stuff done. My 2 cents. Thank you.
Hey, Bill, I know we hear you about asking if they need more resources and the coping mechanism. Any other specific questions that you want to ask to Dr. Johnson?
No, thank you.
And Dr. Johnson, would you like to respond?
Sure. I think that again, I think that there have been ongoing efforts. And in the last decade, I think we've seen a tremendous number of those. I think with, again, this support, and I thank you, Mr. Murray, for your support and offering more resources. I think the key is as we receive, we're going to be getting some opioid settlement dollars. We have some American funding coming in for relief. I know that City Council and our commissioners have been supportive, and there are initiatives coming from our private sectors. Again, I would say that the communication and then integrating these monies so that we are creating a system and a fabric of prevention, resilience, which is what I term our coping mechanisms, but it's having options in your toolbox. Not everything needs a hammer. We need to give people some screwdrivers and a few wrenches so that they can get the project done without just having to hammer on it. But the opportunity for us to come together collectively to create a continuum of care, a fabric that creates truly a safety net, but also a boat that keeps us upstream in that preventive kind of measures rather than actually getting, into having to utilize treatments or our justice systems or arriving finally in the coroner's office. This is where we want to go. And so it is, to your point, Mr. Murray, a really prime time for us to do that. And I think our community is doing those things and bringing it together. And so we'll just bring it back to you more often so that you can hear what is happening and hopefully continue to do the advocacy into the community about how people can get connected to get involved and make that change.
Great, thank you. Any other questions up here on the dais before we take a break?
Real quickly, I just want to say I think it behooves us all, and I look at my fellow council members, to remember what you have said to us today. You're asking us to communicate and to collaborate. And it's a great strategy that you put forward. We don't actually have access to those slides in our link. If you could send those, that would be great.
Yeah, we'll get those. The additional slides that we didn't get from Dr. Kelly.
Yep. So collaboration is a part of the mayor's strategic plan for all kinds of things, and it fits in this topic as well. So thanks so much for the time.
Well, great. And Dr. Johnson, Dr. Kelly, Megan, Kelsey, thanks for spending the last couple of hours with us. We appreciate that very much.